Normally, blue or low oxygen blood returns from the body and is pumped out to the lungs. Red or oxygenated blood returns from the lungs and is pumped out to the body. Tetralogy of Fallot is made up of 4 problems that result in not enough blood flow to the lungs. Complete surgical repair consists of removing the pulmonary valve and opening up the narrowed area out to the lungs by using a patch material. Also, the hole between the bottom chambers of the heart is closed. This allows separation of red and blue blood and augments blood flow to the lungs. Unfortunately, removing the valve allows leaking of blood backwards, which over time results in stretching and weakening of the right ventricle.
Well, Tetralogy of Fallot is a constellation of congenital cardiac anomalies. So there's these 4 things that were described back in the late 1800s by Fallot, and the 4 things are: there's a ventricular septal defect, so there's a hole between the 2 pumping chambers of the heart, a VSD it's often called, and then there's narrowing in the artery that goes to the lungs. So the pulmonary artery, there's narrowing at the valve, and there's often narrowing below the valve. So that's the second thing, pulmonary stenosis or narrowing. The third thing is you have the aorta, the big vessel coming out of the heart, is overriding the ventricular septal defect, and I'll show you what that means when we look at the model. And the final thing is that you have a thickened right ventricle in response essentially to having the hole in the heart and having the narrowing to the lungs. So that all together makes up Tetralogy of Fallot. Usually, babies with Tetralogy of Fallot can present one of 2 ways. They can, you certainly with these days with getting ultrasounds in utero, often it's picked up, not all the time, but it's often picked up, and it can be picked up with a fetal echo. But if not and a baby is born, usually if the baby will present with cyanosis, so the baby will be blue, and that's not often on the first day. There's an artery, the patent ductus arteriosus in a baby, that closes over the first few days of life. So as it closes, there'll be less blood getting to the lungs and the baby will turn bluer. So that can be a way the child presents. Another way the child can present is he can not have too big of a narrowing to his pulmonary artery, so he's getting enough blood to his lungs, enough to stay pink, and he may not develop symptoms till later on in life, whether it's 6 months or a year of age or so on. So in those kids, it's often picked up with a murmur. Symptoms that they have, if a child, things that people should be worried about: does their baby have a congenital heart, really any kind of congenital heart anomaly that causes them to have cyanosis, so low oxygen. And symptoms are blue lips or blue fingertips, and that would be a tip-off. Irritability or difficulty eating, or getting tired when they try to eat, just running out of energy, so maybe they only are able to take in a ½ an ounce when they should be taking in 2 or 3 ounces, just because they work at it so much and they get tired out. So, and then to some extent upper respiratory infections, multiple infections can sometimes be a clue. I think the main thing is they have to be watching for signs of things worsening. So like, is their child gaining weight and eating enough? Because if they're not, then we got to worry about, well, they're too blue and they're not doing well, so maybe we ought to be doing a full repair sooner than waiting the 4 to 6 months. Need to be going to a cardiologist and their pediatrician, and they check the oxygen saturation on their skin. And if it's getting too low, then we worry about that, and we worry about pushing the surgery sooner. In addition, there are these things called TET spells where they'll turn real blue if they have some sort of stress, and the child will do stuff like squat or lift the legs up to the chest, and that kind of forces the blood back to go through the lungs and get more oxygen. That still happens. Fortunately, it doesn't happen as often because we tend to fix them earlier, and we don't see it as much as before when you used to fix it much later in life. But those would be the things you'd watch for that would maybe push you to do it sooner than waiting the 4 to 6 months. Nowadays, we do a complete repair most all the time on children at the age of 4 months, but we will do it earlier if they're blue. Often kids are just a little blue, and maybe their saturation's okay, and they're kind of well balanced, and you can wait till they're four months of age and then do it. If they're not, and they're severely cyanotic and they need to be done early on, then we will do a complete repair, but sometimes there's certain reasons to do a shunt. If they're very small or they're critically ill with other things or they can't have open heart surgery, then we would do that shunt just to get them to a bigger size or an older age and over these other things to do the surgery. Now, the complete repair involves cardiopulmonary bypass, so it's open heart surgery, and we divide the breastbone and open the pericardium, the sac around the heart, and expose the heart. And then I'll put a tube in the heart that will take the blue blood to a machine and give it oxygen and bring it back to the aorta, the artery coming out of the heart, to give the child's brain and body oxygenated blood while we stop the heart. So that's the cardiopulmonary bypass. You're using the machine to bypass the child's heart and the lungs while we work on the heart. And then we'll arrest the heart. We'll use a preservative that keeps the heart cool and keeps it stopped, and then we'll restart it after the operation. But it's a similar thing that we would use if we were to want to use a heart for a transplant. We would stop it with this liquid that stops the heart. And then what we would do then is we would close the hole, that ventricular septal defect. We'd close it with a patch. We'd sew that in there. And then we would open up all this muscle, sometimes cut these muscle bands underneath the pulmonary valve. And then we would look at the pulmonary valve, and if it was big enough and the problem was really the narrowing was at the muscles, we would be done. If the valve, the ring of the valve going to the lungs was too small, we'd have to cut across it and sew a patch there. And that would relieve the obstruction to the lungs. So then it's actually a very good operation, because before they go in, you have these babies that are very blue, and then when they come out, they're pink and they have normal saturations and essentially a normal functioning heart, in that they have 2 pumping chambers, and the blue blood and the red blood are separated by walls that are intact. Acute recovery in the hospital is typically about 5 to 7 days, and again, depending on their age. If you did the operation in a 1-month-old, it would be different than in a 4-month-old. But I think it's safe to say 5 to 7 days in the hospital, and then over the next few weeks they'd be getting stronger at home and be acting pretty normal. But I think that's an important point, because they do act pretty normal after they're repaired, because they have good saturations and they have 2 good functioning ventricles. So you do have to continue to follow up with a cardiologist, your pediatric cardiologist, and they will often want to do an echo or an ultrasound of the heart once a year to make sure things look good, because there's certain things long term that can develop, like we talked about. If you have to cut across that pulmonary valve, well, then that valve is going to leak, and that's tolerated very well in children, but we found that with time in young adults, sometimes even in kids, but in young adults and older adults, their right ventricle, it will make the right ventricle work too hard. It will dilate it out, and the heart will get tired. And so one day we may have to put a pulmonary valve in that position with another open heart surgery, which isn't, that surgery isn't quite as complicated as the first surgery, and it's not a very high risk operation either. If you're doing it at a center that does a lot of adult congenital heart surgery, we tend to do a lot of adult congenital heart surgery. So that's why I was saying earlier that it's a very common operation, putting pulmonary valves in patients who've had tetralogy repair as kids.